All right, now I want to introduce Dr. Jorge A. Ramayo. He is a doctor, a medical director at the Inova Pride Clinic that we were fortunate enough in the Northern Virginia area to have open in 2022, and I'll let him tell you a little bit about how well it's doing. His specialty is internal medicine and pediatrics. He has a very esteemed background, has gotten his Master's of Public Health and his medical degree from Yale University, and many accomplishments and professional relationships. And he is an assistant professor at the University of Virginia. And with that, I'll let Dr. Ramayo take the mic. Thank you so much.
Hi, everyone. Can you hear me? Yes. My name is Jorge Romayo. I am a primary care physician. That's the way I like to describe my practice. Thank you. I have been very fortunate to lead a new initiative within Inova, which is the Inova Pride Clinic. It's a primary care clinic with an LGBTQ plus focus. That's what we like to think about. It's like a primary care that can provide, primary care clinic can provide holistic care to the LGBTQ plus community that's being unfortunately historically neglected for many different reasons. And I'll talk a little bit about like the, healthcare ecosystem of Northern Virginia and what that might be actually. But I was thrilled to have this opportunity to talk about Mpox and vaccines. It's one of the things I do every day, and it's something that I'm really passionate about. I'll give you a little bit of background though. So the Pride Clinic opened in June of 2022. So it literally opened as the surge was happening. So it was very serendipitous as to we had this new place and this new venue that could actually handle this. And we were so fortunate to work with Dr. Wheeler and the rest of the Innova team to actually be able to centralize some of that response and be able to make Pride one of the main places where we could have access to vaccines and partner with the health department to actually be able to have that really going on really quickly, which was great. I'll tell you that when the surge was starting to happen, it was Pride 2022. I had one of my first patients that came to me, young, very savvy gay man who, just wanted primary care. He wanted to be on PrEP. And then I get a message from him the first week and say, hey, they're vaccinating people in New York. Are you doing that? That was the start of that conversation. And then sure enough, that prompted me to reach out to the health department and be like, hey, what are we doing? Who do we know? What can we do to get this here? And sure, soon enough, we're actually providing the vaccine in our clinic, which was a huge success. And that's part of the reason why the uptake on our patient population was so great, especially during this time. So first, though, I want to make sure that we talk about just a overview. I know we have different, the audience is mixed. We have clinicians, we have healthcare educators and healthcare professionals. So I just want to make sure that we're on the same page about like Mpox and the vaccine. So the one we're going to talk about is the Jynneos vaccine. The ACAM vaccine we don't use. It has a lot of nuances, so I don't think it's worth too much time talking about that. So the Jynneos vaccine is the one that we use. It is an attenuated live vaccine. So that means that it's a live virus, but it's like actually not infectious. It's FDA approved for smallpox, Mpox in people age over 18 years. So that happened after the surge actually, so it's a new approval. But it has an emergency use authorization for anybody under the age of 18. So there's gonna be very special cases in which you may want to do this. If you have a teenager that is very high risk, that is actually putting themselves at risk, this might be a case in which you might want to consider doing that. This is the vaccine that we've been using in the current outbreak. And the dose is a 2-dose combination that they actually recommend for people 18 years or older at risk of Mpox in 2023. And we'll talk about the timing and everything else, and you are considered to be actually protected. So the Jynneos vaccine can be provided in 2 ways. You can do the intradermal one. I'm sure you've seen a lot of people getting that. So it's the one that goes in the forearm and it leaves a huge red mark and it's not very pretty. Some people were calling the scarlet letter because you could actually see, and it was very evident who got vaccinated during that time, which people did not love, I'll say that. And then the subcutaneous injection is the one, the subcutaneous injection is the one that, is the typical just in the deltoid, no issue. Initially, we had some issues with supply of the vaccine, which is why we had to go into the intradermal route, and that's why it was the preferred way of administering it. But as the supply has continued to increase, then that is not something that is absolutely necessary. It is a 2-dose series separated by 28 days, so 4 weeks. And you are actually considered to be protected 2 weeks after your second dose. So I had some patients that are like, okay, I'm ready to go. I'm like, no, you're going on a cruise. You're gonna have to make sure that you time it at least 2 weeks before you go on that cruise because you have to be protected. And then the second dose interval, obviously as soon as possible, like the 28 days. But if you have somebody that just received the first one and then they kind of like just went on their way, I'll say we'll go into like protection. They were a little bit protected, but if they come back to you, they're like, hey, you never got your second dose, then you provide it, right? So it doesn't matter. You don't restart the series. You go ahead and give the second one, okay? Healthcare workers don't need to be vaccinated before administering it, so you don't need to be vaccinated to be able to vaccinate other people. However, if you're somebody that is in that setting that you think might be exposed, it's something that you might want to consider. It is safe for most immunocompromised persons, and this is important. This is why HIV patients and people that might be considered high-risk cancer patients that might be exposed, it's something that we use as a strategy to prevent severe disease, because that's actually what prompts you for that. And then you can give at the same time as other vaccines. The only caveat is that if you are administering the COVID vaccine at the same time, we do recommend that some people might want to wait a month in between the two. And it's just like a theoretical risk of increased like issues with, the side effects from the COVID vaccine. But in general, you can provide it. I have a lot of adolescents that come to me. They're getting their HPV vaccine. Sure, you're getting another one of these if you happen to be at risk. So as I mentioned, dose 1, wait for a week. Dose 2, and then 2 weeks after that is when you have max protection against Mpox. And this is just a little graphic that comes from the CDC regarding how to do the intradermal injection. Typically, it's best studied to do it in the forum. It's just the best and most accessible way in which people learn how to do it, which is why we use that site. So the administration, so this is one of the things. So people suspected or confirmed so people that have suspected or confirmed Mpox, so people that are symptomatic that you're testing, should be seen by a clinician for testing and treatment, but not vaccinated. So that's not the recommendation. If you have somebody that has active symptoms, we are not recommending that you provide the vaccine at that time. You obviously are going to test them. Vaccination given after the onset of symptoms of Mpox is not expected to provide benefit. That is why we typically don't recommend that. We don't see that there's going to be a benefit if you vaccinate somebody after they get the infection. So the subcutaneous and intradermal doses, so in the forum or in the deltoid, are interchangeable. So we saw that the immune reaction that you can mount with either administration method is actually very similar. So if you happen to have a lot of vaccine and you give the subcutaneous one, and then you come back and you're running out of vaccines and you're doing the intradermal, that is okay. So the one caveat I've been having, especially at the beginning, is like people that develop keloids and, like really a lot of scarring. Those are the people that I would prioritize giving the subcutaneous vaccine just because it has a less risk of having that issue. And the intradermal use of the vaccine is not approved actually for people under the age of 18. So any pediatric patient you might be vaccinating should receive the subcutaneous time. And this was a big issue for some of my patients. They did not want to get the intradermal. They were adamantly against it. And that's when we had to have conversations. But at the end of the day, if they were like, if that's the way you're going to give it, that's the only way you have it available, I'm not going to get it. That was bottom line. So we had to actually open this up to say, okay, that's fine then. If you have that many concerns, just go ahead and do the subcutaneous. So allowing the patients to have a little bit of choice and a voice in this is very important. And we'll get into vaccine hesitancy a little bit, but this is one of the strategies, right? Listen to your patient. What is the barrier that's preventing them from getting this vaccine? So, and obviously the CDC recommends that you have both options available in your clinic and you have your staff trained to do either one. And yeah, as I mentioned, discuss which one the patient would prefer. In terms of vaccine effectiveness, these are some of the studies that show that the full 2 doses of the vaccine, so the upper part of this, showed a protection between 66 to 86% after the second dose. This is 2 weeks after the second dose. So it's not a perfect vaccine. People can still get sick from Mpox, but it's actually pretty good as vaccines go. And then even the partial 1-dose vaccination showed that it's not as great. So it was like the range was 36 to 75%. So it's not great, but it's still something, right? And as we're trying to prevent not only the spread of Mpox, but also severe disease, if you are able to actually have at least some protection, kind of like COVID, even if you get COVID, you still are less likely to develop severe symptoms and be able and have to be hospitalized for this infection. So again, the effectiveness, usually the symptoms can be milder if you receive at least one dose of the vaccine, better if two. We still have some questions about the people that are actually immunocompromised. So as I said, people with conditions that make them immunocompromised should still get vaccinated, but then you have to wonder, okay, what is going to be the effectiveness of this vaccine for somebody that cannot mount an immune reaction, right? So it's something that you still have to keep an eye out for an infection and just know that the effectiveness might be decreased. And then how long does the protection last? That was one of the questions I was asked. And unfortunately, we don't have great data. We're just starting using this vaccine for this indication very recently. So we don't have that data. It's something that is being worked on right now to determine if I've had so many patients come to me and be like, I'm ready for my booster. I'm like, well, we don't have that data yet, so we're gonna have to wait a little bit, but stay tuned is what I tell them. So people who are vaccinated are encouraged to continue protecting themselves. And these are some of the things that we usually tell patients. We're going to talk about being a sex-positive clinician. I think that's a very key important part of this whole conversation because I've had a lot of patients that refuse to go to the health department or any other like urgent care because they have been shamed before or like because of, you know, what their sexual behaviors were or like their partners, they get that look, you know, the look. So just making sure that you are creating that safe space where people can actually be open about what their practices are so you can actually listen and practice a risk reduction approach in which you can actually tell them, hey, this is what's going on. These are the things that you can do. We talked about avoid close skin to skin contact with people that have a rash that looks like Mpox. So that leads to education about patients. What does Mpox look like? Do you even know? What are the symptoms? When should you be worried when you have a partner? Avoid contact with objects is something that was very widespread during the 22 outbreak, in which like, okay, a towel or something. If you're in a bathhouse and you're sharing a towel with somebody, or like a bench or something like that, are you having skin-to-skin contact with something that might be infected? And washing your hands often. I would also add here the idea of a sexual network. It's something that I've been talking to my patients a lot about, especially as we're talking about doxypep a little bit, into what is a high-risk encounter. And I tell them that if you have if you're a non-monogamous partner and you have a few sexual partners, the higher the number, obviously, the higher the risk, but also you have to think about who is it? Is it somebody that you know, that you trust, that gets tested, that you have this communication with? Or is it somebody that's totally random, that you have no clue who they are, and what type of sexual contact did you have? Did you wear a condom? Were you the receptive partner? All those questions are important to determine their risk, right? But having those conversations with the patient can go a really long way. Post-exposure prophylaxis is something I want to talk about. So that this is one strategy for patients that were either they know that they had a contact with somebody with Mpox, or it is suspected that they had an exposure to Mpox. So if we have somebody in this circumstance, and know that this is not somebody that actually has active symptoms, it's somebody that's coming to you and saying, I think I was exposed. So that's a great use of this vaccine because you can actually give the vaccine. The sooner you can do it, the better. Usually, ideally within 4 days is the highest protection you can receive. But there's some research that shows you can give it up to 14 days after the exposure and still have some protection. So that's usually the best use of this strategy. And it's the main use I've seen for pediatric patients, actually, in which maybe the parent was the one that was exposed. The kids were exposed to the parent that had it. So let's talk about eligibility in Virginia. I think this is an important slide for people to know. I think initially when we had like limited supplies of the vaccine, this changed a lot. And then there were some people that are like, well, are you even sexually active? Do you even qualify for this? And there was a lot of confusion that actually happened in the community. And they were like, well, they're not giving it because I wasn't sexually active enough or something like that, right? So now I think that it's broad enough that we can actually think about this more practically, so that way you can actually think about like, who are the patients in my practice or that I'm seeing that might really benefit from this, right? So you had a known exposure or suspected exposure and within the past 2 weeks. That's PEP. So they qualify, you should definitely offer it or refer them to the health department. You are a gay, bisexual, or older man who has sex with men. So notice it is a binary language in which like gender is identified, which is actually on purpose because later they put transgender, non-binary, or gender diverse person. So that means that, gender identity has something to do with this because trans women have actually been historically affected by this as well. But it is anybody that's having with people assigned male at birth that might be at risk to have multiple partners. And that's an important distinction and a way to not exclude a whole segment of this population, right? In the past 6 months, had a new diagnosis of an STI, so that's always a red flag. So if you have somebody that's being treated for syphilis, gonorrhea, chlamydia, you should be thinking about PrEP and Mpox vaccines. And then, or they have more than one sex partner. So if they actually qualify for the vaccine and they're not on PrEP, you probably need to talk about PrEP. And if they are on PrEP, they probably qualify for the vaccine. So that's one of the links I usually make. It's like, okay, are you on PrEP? Have we talked about you be receiving the Mpox vaccine? You've had any of the following in the past 6 months. So sex at a commercial sex venue, like a sex club or a bathhouse. So if you've actually frequented one of these places, your risk is higher. So you should think about that. Or you had sex related to a large commercial event in a geographic area. So that's mainly like, the pride events that usually happen in the summer, things like that. So those would be the cases in which you might think about Mpox. I think vaccination. I think it's really broad. Honestly, in my practice with the patient population I see, if anybody's coming to me asking for an Mpox vaccine, they probably have a reason. And I'm not going to question that too hard. I'm just going to say, okay. I love that the health department is now asking, hey, do you meet any of this criteria, yes or no? Because before it was like, tell me exactly which one is it. And that was a very uncomfortable phone call with a random stranger that you were having to have. And it was not very sex positive or very inclusive at the beginning. So I'm glad that that's something that's changed. And, usually like online forums are a really great way of getting that information without having to you make somebody feel a certain way. If you have a sex partner with any of the risks that I already mentioned, you probably should also receive the vaccine. Or if you anticipate that any of these things are going to happen. So I may have somebody that is a monogamous relationship, they're with their partner, but they're like, hey, we're going to go on a trip and something might happen. I think I need a vaccine. Sure, here you go. You have it. No problem. So if you work in settings where you might be exposed to Mpox, this is for my nurse, this is for my medical assistant, that's when we might think about vaccinating the staff as well. So like we mentioned, right, they don't need to specify which criteria they meet. They just need to say that they meet one criteria and then they can go ahead and get it. And the VDH website actually has a lot of great information, handouts, things like that. So I do highly recommend people save that. And as of October 2022, the health departments allow entrusted partners in the community to be able to vaccinate in their offices. It's actually a very seamless process. They're so helpful. I can get a vaccine shipped overnight for me and be able to vaccinate my patients. So it's something that's actually been very, very useful. So know your contacts at your health departments to make sure you can actually make this happen. And then the CDC Mpox vaccine locator is actually a really great tool and is very up to date. So it's actually a great way to find, if you don't happen to have the vaccine in practice, but you have patients that need it, a great way to kind of find it. So this is the number of vaccines administered based on the dashboard. This was updated I actually looked at it on the 16th of January. So there were 13,118 first doses that were given and only 9,842. So there's definitely a gap there and there's more work to be done to be able to completely vaccinate the group. They do estimates about what % of the at-risk population needs to be vaccinated to prevent another outbreak. And what I saw recently was about 50%, which we're not close to. So the more we can vaccinate, and right now it's actually a great time to prevent another outbreak from happening again this summer. Remember, Pride happens in June. There's many events, and that's usually the time where people might be engaging in more risky behaviors, and we have to be prepared for that. Let's talk about who we're trying to help and where we're trying to, who is this population? So the LGBTQ plus population, I think I'm preaching to the choir here, but there's a number that's certainly rapidly increasing. In this Gallup poll from 2022, it went up to 7.1%. And I can tell you for teenagers and just adolescents in general, that number is actually higher. So a lot of people are not necessarily identifying as straight. They're opening their mind about other sexual practices. They're maybe thinking more openly about what does it mean to be a sexually active person and with what partners. So it's something that is actually changing, and our understanding of human sexuality is also changing with that. we're talking about health equity. I think it's something so important. I love the question about like, what are we doing about like reaching these at-risk communities? Like, like even though the Black queer community may not necessarily be like the majority of the LGBTQ plus community in Northern Virginia, they are disproportionately affected by this. And the reason is multifaceted, right? So we're not reaching that specific population. We're not actually maybe getting the right people involved and like getting the word out. We're not having access. That's one of the big issues that a lot of my patients are unfortunately experienced before, and that they didn't have access to an affirming sex positive provider that can actually provide holistic care for them. So it's a bigger issue. I think it's a symptom of a bigger issue that we have as a system that we need to continue working on. But our health department and allies need to be very keenly aware of this and be able to find the places that are actually serving these communities to be able to be effective, right? And I actually want to commend the health department because it was a great partnership from the very beginning about like just getting the vaccine where it was needed in Northern Virginia. So I think that we are trying our best, but it's a very difficult thing to do oftentimes. We talked about, this slide was actually highlighted before, but I want to highlight it again. So 30%, and this is from January 2024, so 30% of cases were white, 40% were African American, 10% were Latino. So definitely a lot of disparities there. I've talked about like being a sex positive clinician. That's one of the things that I really love to talk about just because I want to make sure that when a patient walks into your clinic or your department, like they can feel that they can trust you and they can talk openly, right? So some of the things to avoid that I usually tell other clinicians, it's like, are you sexually active? It has this like tone to be like, are you though? So it doesn't really, it's not specific. You want to give a time frame, right? So in the last 3 months, have you had any partners? What are the sex of your partners? Things like that. Do you have a girlfriend? That's happened to me. So assuming heterosexuality is the default is something that could actually be very off-putting from the get-go. And remember, the clinician-patient relation is based on trust. So if you start off just being like, oh yeah, so this is, you're doing something that might be wrong in their eyes, or they perceive you to not be an open-minded clinician, then that can definitely like damage that relationship from the get-go, and that can limit your ability to help that person. You have sex with men, women, or both. It is, again, assuming like it's excluding gender expansive people. What are the genders of your partners? Something simple like that. Do you use protection, right? Again, something that has that tone. So, protection is more than just condoms, right? So how do you protect yourself from STIs? A little different, but it makes a difference. You haven't had other partners, right? Again, that tone is there, so there's that judgy kind of feel. So just being like, how many partners? Just leave it broad and allow the patient to answer freely. And then ovarian to clinical, right? Have you had insertive anal intercourse? What does that mean, right? For the patient, like use their language, say top, bottom versus side. Like, what are you doing? What's going on? And then my personal favorite is just being like, okay, you're top, bottom versus side. Any kinky play or any like high risk activities is what I tell them. And then after that, I tell them, okay, condom use 100%, 50%, 0%. So I give them like a scale so they can tell me 30%. I'm just like, okay, 20%. But allows them to have that option and not really feel like guilted and ashamed. And I try to normalize it at the beginning, being like, I ask this of all my patients. It's helpful for me to know, and you can share as much or as little as you want. The other thing is representation and outreach. This is Dr. Dimitri Daskalakis. I'm sure many of you are very aware of him. He is the lead Mpox person for the CDC, and the White House appointed him. He is an out gay clinician. He is part of the community, and he's been doing a lot of this really great work at a national scale. And he's part of the reason why we've been so successful in getting a lot of the people vaccinated. Obviously, there's more work to be done, but this just highlights the need to include those voices into the conversation when you're making decisions about strategy, where to go, who to reach out to, how to best approach that messaging. Making sure that those voices are included is very important because sometimes we can actually have blind spots that we didn't realize. So just making sure that your community partners are definitely parts of these conversations is very, very important. Those are the main things I have, and I'll be happy to answer any questions. Thank you for your attention.